Tumors of the esophagus. Esophageal cancers are common but lethal malignancies seen worldwide. There are two major histologic types: the squamous cell carcinoma, which is the more common cell type, and adenocarcinoma. Both have same clinical presentation but different causative factors. Squamous cell carcinoma, epidemiology, it is the more common cell type. Familial increased risk has been observed and more common in blacks than in whites. It has a male preponderance than female, most often seen after the age of 50, and it is associated with lower socioeconomic status and generally arise in the cervical and thoracic portions of the esophagus. The etiology for squamous cell carcinoma, there is excess alcohol consumption, cigarette smoking, wherein the relative risk is related to the amount of cigarette smoked or alcohol consumed. Whiskey is linked to be higher incidence than wine. We have also ingested carcinogens such as the nitrates, smoked opiates, fungal toxin in pickled vegetables, mucosal damage from physical agents such as hot tea, lye, radiation-induced strictures, and chronic achalasia. We have the host susceptibility, esophageal web. We have the Plummer-Vinson and Patterson-Kelly syndromes, congenital hyperkeratosis, and vitamin and mineral deficiencies. While the adenocarcinoma type, there is increasing incidence of adenocarcinoma. It accounts for more than 75% of all esophageal cancers, usually seen at the distal esophagus and arise within the dysplastic columnar epithelium in the distal esophagus, and around 15% overexpress HER2 neo gene. While some of the etiology of this cancer share with squamous cell CA, but it is more related with chronic gastroesophageal reflux and obesity, leading to Barrett's esophagus. It is also seen more among males and also patients who are smoker. Clinical features of esophageal cancer commonly presents with dysphagia. Usually this dysphagia is progressive, starting from solid foods, then to semi-solids, and then to liquids. And dysphagia occurs when more than 60% of the lumen is involved. As you will see, the most commonly involved part of the esophagus is the lower third, occurring as much as 75%, and the least is the upper third, which is 5%. The patient can also present with weight loss because of nutritional embarrassment of the patient due to the difficulty of swallowing. The patient can also present with painful swallowing, odynophagia, regurgitation, vomiting, fistula, especially between the trachea and the esophagus, and hypercalcemia. The sites of metastasis commonly involves the supraclavicular lymph nodes, lungs, liver, pleura, and bone. To diagnose esophageal cancer, previously we used barium swallow or the esophagogram, but because of these newer modalities of testing, we seldom use this X-ray procedure already. Endoscopy should be done in all patients suspected of having esophageal abnormality, both to visualize and localize the tumor, and obtain histologic samples to confirm the diagnosis. CT scan is also done examining for the possible tumor spread in the mediastinum and para-aortic lymph nodes, and also by endoscopic ultrasound. PET scan also provides assessment of the distant metastasis. These are the different images produced by the esophagus telling us that there are some abnormalities. In this figure, here This is the barium swallow. As you can see, there is stricturing or narrowing over this area, which represents the mass in the esophagus. While this is a direct visualization of the mass using the endoscopy. Here in the CT scan, you have the trachea here, and somewhat a thickened wall can be seen behind the trachea, and that is the wall of the esophagus infiltrated by a tumor. This one is a PET scan. As you can see, there are light signals uh, giving us the interpretation of increase in metabolic activity in this area, which is the esophagus. And this is the endoscopic ultrasound. This is the scope, and the tumor is being pointed here with the white arrow. Treatment. Usually, esophageal cancer has poor prognosis with 5-year survival rate of 10% after the patient has been diagnosed. Thus, the management focuses on the symptom control. Resection is only feasible in 45% of cases, and residual tumor cells are frequently present at the resection margins. Esophagectomies are associated with 5% postoperative mortality rate due to anastomotic fistula, saphrenic abscess, and cardiopulmonary complications. Monoclonal antibody for those expressing HER2 neogene appeared to enhance the likelihood of benefit. Combination of chemotherapy and radiotherapy followed by surgery was noted to be beneficial. And for the incurable, surgically unresectable patients, palliative measures are done. Mostly the issues are malnutrition, dysphagia, and management of tracheoesophageal fistula. Thus, the approach are endoscopic dilatation, wherein you put balloon to and inflate the balloon to dilate the narrowed portion of the esophagus. Metal stent placement. This is also with the use of endoscope and use a self-expanding metal stent just to dilate and allow the passage of food from the mouth to the stomach. Gastrostomy tube or jejunostomy tube placement, wherein you bypass the esophagus and let the patient feed by these tubes, and radiation therapy.